Hello, and welcome to Joint Ventures. In this OSC original podcast, we take a look at recent medical news, trends, and headlines. We're here to dig through the research, pulling together the information that you need to understand these rather complex topics. Our goal is to be a trusted resource to help you make better decisions about your healthcare. Now, before we get too far into today's topic, let us introduce ourselves. I'm Dr. Jenny Andrus, and I'm an interventional pain management physician at Orthopedic and Spine Center in Newport News, Virginia.
And I'm Dr. Andrew Martin. I'm a pain psychologist at Orthopedic and Spine Center. I work with the pain management and orthopedics teams to help reduce and manage chronic pain.
Now, today we're talking about a really interesting pilot program for the management of fibromyalgia syndrome. I may say fibro for short. Fibromyalgia syndrome is a controversial diagnosis. It's characterized by widespread pain and then a constellation of associated symptoms like fatigue, cognitive problems, kind of like brain fog, or poor sleep. And it's often seen in conjunction with other diagnoses like irritable bowel syndrome or chronic fatigue syndrome. Now, this is a controversial diagnosis because it's actually really just a group of symptoms or constellation of symptoms without a clear cause. There really isn't a specific confirmatory test, and oftentimes patients will have problems like rheumatoid arthritis that will have a clear diagnostic marker, but they'll also get the diagnosis of fibromyalgia because of this widespread pain. There is very significant overlap between fibro and emotional disorders. And in fact, many of the patients who are diagnosed with fibro may also have depression, anxiety, and other mental health problems. So, and having a history of trauma, particularly adverse childhood events, is highly associated with this widespread pain. So as you can imagine, a lot of doctors have concerns about the diagnosis. And I personally think it is highly overutilized. And overutilization results in three big problems. The first is that since so many people are diagnosed with fibro, when their symptoms could be attributable to other illnesses, that actually lends to the idea that it's not a real disorder. It kind of then lends people to diminish the difficulties that widespread pain is causing the patient. So that first problem is overdiagnosis leading to minimization, sort of crying wolf. The second is that just as soon as someone gets that diagnosis of fibromyalgia syndrome, every ache and pain gets blamed on it. And I've seen important diagnoses missed by providers because the provider or the patient attributed everything to the syndrome. And the third and probably most detrimental one in my mind is that once given that diagnosis, many patients get defeated. They start thinking they have this disabling forever problem that they're never going to get better from. They can't control it. And I've seen patients get really wrapped up in their symptoms or finding a treatment or a cure. And they focus so much on the fibro that they're no longer focusing on their day-to-day lives and living successfully. Now, in our medical system, if you have something that hurts, you go to the doctor, and people expect some type of treatment. And fortunately or unfortunately, most of the time that treatment's a medicine. The current standard of care medicines for fibromyalgia help about 30% of the time, and that is not great when you consider that 2 out of 3 patients are really not getting a lot of relief. So in a recent article, the Mayo Clinic has been working with a digital platform to develop an emerging gold standard for treatment for fibro. Cognitive behavioral therapy and other non-medication options have shown much better results in the medicine, like 60% of patients noting improvement as opposed to 30% with a prescription pill. So in this proof of concept study, patients met with a provider and they used digital resources like chat-based interaction. Medicines could still be used. And of the 140 patients in this pilot, there was significant improvement in pain, but even more so, improvement in activity tolerance or functionality. A randomized clinical trial is planned to see if these results are replicable, and if so, that would provide a structured framework for fibromyalgia therapy, which is primarily focused on patient self-care and not on medical interventions. So as the expert in cognitive behavioral therapy at OSC, did any of this surprise you?
No. In fact, I see this every week in my practice, and it's really the best part of my job. People telling me that they can get more done, they feel better about themselves, they have fewer pain flare-ups and less pain. And I see those results in questionnaires I give people about how the pain is affecting their life as well.
because they love filling out paperwork, right?
Oh, yeah. Everybody loves those. When you've had chronic pain for so long, it can be hard to imagine it ever changing, and it's easy to feel helpless, and the questionnaires help show people their hard work is paying off. Sometimes it's like an aha moment. They sense they were doing better, but the questionnaires and feedback help put it in a way that we usually don't think about our pain.
I'm really excited that this pilot program might give more validity to what behavioral health can actually do in terms of pain management. It's hard to get patients to try cognitive behavioral therapy, and I just think we unfortunately minimize the impact or role of emotions in pain.
Yes, I think that's the most critical step is somebody walking through my door. Now, you particularly, but a lot of the OSC providers are great at explaining how psychology might help in a way that gets people to come through my door. And I've always wanted to ask you, how do you do that?
Not telling, that is my trade secret. But no, honestly, I go to the studies. I think people are better able to see the value in this when they can see data supporting it works.
Okay. Yeah, that's similar to how I explain it. I say your pain is real. It's not in your mind, meaning it's not made up or imagined. Chronic pain is nobody's fault, and it doesn't mean that there's anything wrong with you as a person. It's not a sign that you have mental health problems necessarily. It's actually a sign that the brain is working as designed, just on a problem that it's not good at dealing with. So we're used to thinking of pain as only being affected by what's happening in the body. But that's not true because it just takes a bad mood for pain to get worse. We've all experienced that. And I hear that frequently from my patients. And then there are the placebo studies.
We do know Dr. Martin loves a placebo study, so go ahead, sir.
Thank you. Thank you. So placebo studies involve giving someone a fake treatment, like a sugar pill, and telling them that it's a treatment. Placebo studies on pain show that even when given a sugar pill, if told it's a pain treatment, people report a reduction in pain. So it's not the pill, but something about the idea that one is getting treatment that reduces the pain. We see the opposite as well. We can give people a powerful narcotic, but tell them it's just a sugar pill, and then they will report that their pain is unchanged. Here's a very bizarre one. I can teach people coping skills for dealing with chronic pain. They never use any of them, and yet still report their pain is reduced. I'll say that one more time. I teach coping skills. The person never uses any of them and still reports their pain goes down. And then one more, and I'll stop with the placebo stuff. So in World War II, an army doctor noticed that something odd when he treated the victims of an attack on a European village. He was treating service members and villagers with significant injuries, and noticed the service members reported significantly less pain and requested less pain medication than the villagers. So first thought might be, well, that's because soldiers are tougher and they're trained to deal with injury. But these injuries were beyond tough guy or training. I mean, these were traumatic amputations, third-degree burns all over the body. The difference was the villagers' injuries meant they were now maimed, living in a war zone. The soldiers' injuries meant they were going to go home from the war, out of danger, and to their families. And that significantly changed what was happening in their brains, and so changed their pain experience too.
So clearly the brain has something to say about how much pain we experience. So let's dig into that a little bit, getting back to what I was saying earlier, how our brains are built for survival in emergencies, not long-term problems.
Okay, so a lot of you have probably heard the phrase fight or flight. That's where the brain senses possible danger, and then faster than we can think, it makes a bunch of changes designed to help us fight, run away, or freeze in place. It sends blood to the major muscle groups, increases heart rate and breathing. Finally, the most important thing the brain does, and does wrong for chronic pain, is it focuses us on the threat. Now, if that's a bear chasing us, great. We don't want to get distracted by the trees and butterflies while we're coping with this bear. But what if the threat is chronic pain? The brain stares down the pain, letting in and processing more and more pain signals, resulting in more real pain experienced. And I understand the process like that can actually change the brain over time?
Yeah, you can see on an MRI where chronic pain can lead to growth in parts of the brain designed to anticipate or process that pain. And we see the opposite when that chronic pain is reduced via medical intervention or practicing relaxation techniques. Those areas will actually shrink back down, and that's what you focus on is ways to relax the nervous system.
Yeah, so cognitive therapy for chronic pain is basically a collection of every technique we know to relax the nervous system in the short and long term and take it out of fight or flight mode so it stops processing so many pain signals.
So, kind of what's the time commitment that a patient would have to expect, and what are some of the techniques you would review?
Okay, so it usually takes about 10 sessions meeting twice a week for an hour each meeting to learn all the techniques the most efficiently. If you get more than a week in between sessions, it starts to take more sessions to achieve the same results. The techniques range from the very simple and immediately effective to the frankly strange, challenging to learn, but more effective in the long run. So a simple technique is meditation or mindfulness designed for chronic pain. Probably the most complicated technique learned is cognitive restructuring or thought changing. So our brain is always thinking, and most of those thoughts happen without our awareness. And yet those thoughts can affect the nervous system and therefore our pain levels. So cognitive restructuring involves learning how to see those thoughts, logically analyze them, and if they're making our pain worse, tweak them.
Now, a lot of patients with fibromyalgia are complex with physical pain, emotional dysregulation, and trauma. So how do you handle that? What do you work on first?
Yeah. Well, so undertreated or untreated anxiety, depression, and traumatic stress symptoms also put a strain on the nervous system, putting it in fight or flight mode and therefore increasing our pain. Sometimes I'll be treating a person for mental health, not knowing they have chronic pain until they tell me. And it usually happens like this. We made a lot of progress resolving a past trauma, and the person comes in and says, "My back doesn't hurt anymore." Well, it does still hurt because there's something wrong with their back, but it's like the volume has been turned down on the pain. It's difficult to tell what's contributing to what, so I usually teach patients about the treatment for each and ask them to choose which they'd like to address first. In cases where people have unresolved emotional trauma, they usually ask to work on that first, and we see, does their physical pain reduce when the emotional pain reduces? And if not, then we shift gears and work on the physical pain. Other times we focus on the physical pain first, and as that reduces, the anxiety and depression, and sometimes even the traumatic stress symptoms reduce.
Well, this pilot study really highlights that cognitive behavioral therapy is likely to become the gold standard treatment for fibro, which hopefully will reduce stigma, improve utilization, and ultimately hopefully see a lot of people feeling better. Thank you so much for tuning in. Please subscribe to this podcast. We don't want you to miss out on any of our newest content. Wishing you good health. See you soon. Bye-bye.
At Orthopedic and Spine Center, we're dedicated to providing the highest quality treatment using the most advanced technology available. Our fellowship-trained spine and interventional pain management physicians specialize in diagnosing painful conditions and offer minimally invasive interventions to complex spine surgeries. Our pain psychologist helps patients understand and reduce stress from chronic pain conditions. Our experienced physicians get you back to doing what you love. Call today for an appointment. Experience excellence at Orthopedic and Spine Center.